Actually. So, triangular fibrocartilaginous complex. Triangular fibrocartilaginous complex, as you can understand, that there is triangular fibrocartilage. Along with that, there are other ligaments. Together is known as triangular fibrocartilaginous complex. So, what are the components of the triangular fibrocartilaginous complex? So, the most important part, the central part, is your articular disc or triangular fibrocartilage, and many ligaments around it. So one important ligament which is holding it like two hand is the palmar or volar radio-ulnar ligament on the volar side. It is one arm and another arm, like two arm it is encircling. It is dorsal radio-ulnar ligament. So this is encircling the articular disc. So apart from that, what else are there? So the most superficial, if you are coming from the ulnar side, this is the sheath, tendon sheath of the extensor carpi ulnaris tendon. After that, there is ulnar collateral ligament, this one. After that, which is not seen here, in this area, like if I am drawing here, there is a layer of meniscus homologue. So this is the, if we are looking from the superficial, so the third layer of this ligament is your meniscus homologue. After that, we are having the three ligament from the volar side or palmar side. One of them from ulna, this one, from ulna to lunate, ulno-lunate ligament. Then this is one little big. Going through the lunate, we'll be seeing little bit of lunate bone when we'll be seeing this ligament. So this is ulno-capitate ligament coming to the capitate, and another is ulno-tricutrial ligament, which is the next after the meniscus homologue. So these are the different layers what we will be able to see there. And I have tried to draw here a little bit. If you are holding our probe here in this part, what we'll be seeing first is the tendon sheath of the extensor carpi ulnaris. After that is your ulnar collateral ligament. After that is your meniscus homologue. And then the three ligaments, the ulnotricutrial, ulnocapitate, and ulnolunate. And these are the two arms which is encircling the articular disc. This is the articular disc, one from this side, another from the other side. So with this, my volunteer is sitting here. So I'll be demonstrating you. So first, I'll be starting with the scanning it from palmar side, and my aspect marker is towards the radial side. Let me unreach. So my aspect marker on the left side of the screen, and I'm starting from here. You can understand this side is your radius. This is your pronator quadratus muscle. This is your ulna. This bone is your ulna. And now what I'm doing, I'm gradually coming down. So this is, I have taken ulna in the middle. This is the radius, and I'm gradually coming down. This is ulna, and now this is radius. And now see, let me hold it like this. So pronator quadratus muscle. Okay, so this is ulna. And now suddenly the ulna will be vanished. So when the ulna is vanished there at this position, so you can see just give me a second. Huh? I'm just just give me a minute. Ah, no. Okay, so now it's working. There was some problem with the machine. So what I was telling that I was here. So one side is your, this side is your radius, this side is your ulna, and now I am sliding it down. The ulna is coming superficial, and then ulna is vanishing. So now ulna is vanishing. When the ulna is vanishing at this point, so there is a ligamental structure. So one side I can see the radius till. So machine is getting hanged up. Okay, please give me some time. Meanwhile, you can ask me the question and say I'm changing the machine. So there is some problem in the machine. Benefit the machine. It is a touchscreen machine, but unfortunately, none of the button is working nicely. Okay, so if you have till the other machine is coming, if you are having any questions, you can ask me regarding the last class. No question? Are you there? Can you hear me?
Yes, sir. We can hear you, sir.
I cannot hear anyone's voice. So I was thinking whether I am audible. I'm extremely sorry, series. Suddenly what happened? The machine button is not working. Touch screen is not working. I am unable to even shut it down. I was thinking to shut it down and you know. So no questions for the last class raised. Okay, so let me recapitulate some of the structures. Like what are the carpal bones? Carpal bones are one is the proximal row, another is distal row. So proximal row, what are the bones there? It was last day discussed yesterday. It is like an inverted C or inverted U. So first bone is your scaphoid, then your lunate. Remember the lunate is the most superficial bone. Then is your triquetral and pisiform sitting over there. The second row, trapezium, trapezoid, then your capitate is a very big bone, and there hamate, and there is a hook. The hook of the hamate is there. So these are the different carpal bones. And we again had the few other things what we discussed, that the radius normally articulates with the scaphoid partly and the lunate. And scaphoid articulates with the first and the second metacarpal bone. Hamate normally articulates with the last two, means fourth and fifth. And capitate articulates with the third metacarpal bones. So these are little bit of bony anatomy recapitulation. Then another very important thing what we discussed there yesterday, last day, was the different tendons, different compartments, dorsal compartments. So there are 6 dorsal compartment. First compartment, there are 2 tendons. The tendons was abductor pollicis longus and extensor pollicis brevis. So what we discussed, the initial 5 tendons are alternating, longus brevis, like that. And it first tendon starts with A, that is abductor pollicis longus. After that, all subsequent tendons are with E. So okay, I am extremely sorry. My other machine is ready. Let me see whether it is seen or not. Okay, it is seen. Let me make it virtual convex. So my aspect marker is towards the left side. And I was at this level. So the bone, what was here, this was your radius, this was your ulna, this was your proliter quadratus muscle. So now I was holding coming the probe towards the ulnar side, and I am coming down. When I'm coming down, ulna is getting more superficial, more superficial. This bone is radius, and then ulna is becoming very prominent, and then suddenly the bone will be vanishing. When the bone is vanishing, now radius is getting, so this is your okay. So what I was telling here, that after this ulna was vanished, so this ligament is your, this is palmar side, this is your palmar's radio-ulnar ligament. And very little bit seen here, this is your, the dorsal radio-ulnar ligament. And this part, which is anechoic or hypoechoic, is your articular disc. So now, if I am going from here to the, so I was first was first here and then vanished, and now I'm going this side. So if I'm going here, then I am over this bone is your ulnar styloid process. If I'm going down, then the ulnar bone is vanishing. And if I'm tilting my probe, then you can see the articular disc and the two arms of the dorsal and the palmar ridge. Okay, let me clear the annotation. So this was the dorsal palmar, and this was the dorsal radioulnar ligament. And if I'm holding the probe, my proximal side was left hand side is the proximal side. So what you can see here is this. Okay. So most superficial layer was what? The most superficial layer was
Tendon sheet of external.
tendon sheath. After that, this layer is your ulnar collateral ligament, the second layer. After that, this is your meniscus homologue. This bone is your triquetral bone. This is your lunate bone. And this very small hyperechoic thing what is seen is your radius. Because here, if you are looking from the lateral side, the radius is little longer than the ulna. So when this is the ulna, I am holding the probe here, then what you can see, the very small amount of radius is seen from distally. This part is your articular disc. And here is your ulnotriquetral ligament. And here is your ulnolunate ligament. And here it will be coming the ulnocapital ligament, which is not seen anyway. I'm showing you right now. So let me clear the drawing. And let me show you again. So I was holding the probe here. Left hand side is the proximal side. And this was the tendon. This is the picture. This is the picture. Yes. So you can see the same triquetral, lunate. Here radius is not seen, it can be seen here. And you can see the three layers, and this is your meniscus homologue. This is your ulnar collateral ligament. And upper part is the tendon sheath of the okay, so this was a little bit about because some of you requested for it. So this was the triangular fibrocartilaginous complex. Now I'll be coming to today's lecture, today's anatomy, and then we'll be discussing demonstration, what I told, what will be following. So let me share the screen. See, my screen is visible.
Yes, sir.
Okay, first the bony part. Let me reduce it. So we ended with the carpal bones, and now today is the hand will be going beyond the carpal bone. Let me remove all the connective tissue also. So after the carpal bones, so we are having after the distal carpal row layer of the carpal bones, I should say, the metacarpal bones comes. The first, second, third, fourth, and fifth. So as we told earlier, the first articulates with trapezium, Second articulates with trapezoid. Third articulates with capitate. Fourth and fifth articulates with the hamate. So trapezium and trapezoid in articulates with the scaphoid. So now this bone, that means this metacarpal bones have the base. This side is the base and the shaft, and this is the head. And then we are having the proximal phalanx, distal phalanx, middle phalanx, and distal phalanx. For the first, we are having the proximal and the distal. So with this, the bone, let we add the different muscle layer. Let me add all the muscle layer, and then we'll be focusing one by one. So all these muscles can be broadly divided into three. One is this side is your thinner muscles, and this side is your hypothinner muscles. So first, let us start discussions with the thinner muscles. So the most superficial muscle on the thinner side is your abductor pollicis brevis. So abductor pollicis brevis abducts. Where it is attached? It is attached at the scaphoid bone. So it is attached at the scaphoid bone, and origin, I should say, and insertion at the base of the proximal phalangeal bone. So this is your most superficial of the thinner muscles. Then if I'm removing it, then the next layer muscle, which is little bit more medial, more lateral side is your opponent's pollicis. This is the opponent's pollicis, but little more here is your flexor pollicis brevis. Again, flexor pollicis brevis has two heads. You can see this is one head, this is another, and in between the flexor pollicis longus tendon, which is coming from the forearm, is coming, and it gets attached with the distal phalanx of the first finger. So what is the attachment here? This attached little distally. The most superficial thinner muscle was the abductor pollicis brevis, which was getting attached with the scaphoid, but the flexor pollicis brevis gets attached with the trapezium and the trapezoid. And it is inserted where? It is inserted same conjointly with the abductor pollicis brevis at the base of the proximal phalanx. So let me remove it. Then comes is your opponent's pollicis. Opponent's pollicis is the most deep amongst this lateral side of the thinner muscles, but it is lateral than the flexor pollicis brevis. So where from it is originated? It is originated the tubercle of the trapezium, but it is not coming up to the distal phalanx or the phalanx. It is attached at the base of the metacarpal bone itself. So after that, we are having, so already I have talked about this, the flexor pollicis longus. Flexor pollicis longus goes between the flexor pollicis brevis muscle. Then comes adductor. So the adductor pollicis, and it is having the two head. So adductor pollicis, this is your oblique head, which is originating from the first metacarpophalangeal joint and getting attached in the base of the middle phalanx, third phalanx, and part is also attached at the capitate bone. And then it is also having one transverse band. So we'll be able to visualize both the oblique as well as the transverse band. And it is getting attached at the, let me show you these muscles individually. So it is getting attached at the third metacarpal bone, at the shaft of the third metacarpal bone. So these are about the thinner muscles. So again, let us recapitulate what was the thinner muscles. I know many of us, okay, let me go with the muscle layer. Let me recapitulate the muscles. Normally, for the chronic pain, there are not much pathologies. So normally we ignore the hand, the thinner, hypothinner, lumbricals. So we ignore it, but we must be knowing some of it, and it is not that difficult. So first is thinner. So thinner, what is the most superficial muscle? Most superficial muscle on the thinner side was the what? Abductor pollicis brevis. And after that is your flexor pollicis brevis. But if we are coming to the lateral side, if you are removing the abductor pollicis brevis, the opponent's pollicis brevis is more to the lateral side and little below than that of the flexor pollicis brevis. And within the flexor pollicis brevis, we are having this flexor pollicis longus. And then what else in the thinner side? In the thinner side, we also had the flexor pollicis. So the flexor pollicis, again, we are having the adductor pollicis. Adductor pollicis has the two head. This was the oblique head, and this was your transverse head. These two muscles lies below the lumbricals. I'll be talking about the lumbricals later on. First, let us come to the hypothenar area. Hypothenar, this is a very small muscle, palmaris brevis. It is like a platysma. It is very thin, and many times it is difficult to see in the ultrasound. After that, exactly in the same way, the three important muscles on the thumb side was what? First was your abductor, then was your flexor, and then was your opponents. The same way here, instead of pollicis, here it will be abductor digiti minimi, flexor digiti minimi, and opponents digiti minimi. These are the three layers on the hypothenar side. So most of superficial one is abductor digiti minimi, and where it is getting attached, it is it is a longer muscle, so it must be attached little bit of proximal row of the carpal bones. So it should be originating on the thinner side. Hypothenar side is your pisiform. So it is originating in the pisiform, and it is attached where it is on the medial side of the base of the proximal phalanx. And then if we are removing it, then we are having the flexor. So this is the flexor. Where from it should be attached? It should get the distal row. That means hook of the hamate. So this was the flexor digiti minimi. This side it was flexor pollicis. Here it is your flexor digiti minimi. If we are removing the flexor digiti, and then we'll be getting the opponents digiti minimi. So these are the hypothenar muscles. So let us remove all the thinner and the hypothenar muscles. And then we'll be discussing about the lumbricals. So the lumbricals are the superficial muscles. Lumbricals, it is not originating from the bone. Lumbricals originates from the tendon of the flexor digitorum profundus. If you can remember, there are two tendons growing together, flexor digitorum superficialis. This was the flexor digitorum superficialis, and below that, we was having the flexor digitorum profundus. So from these flexor tendons, this was the flexor tendons from where the lumbrical muscles are getting originated. So let me show you individually the lumbrical muscles. So these are the lumbrical muscles. So if I'm going in this side, you can see it is not getting attached to the bone. And how many lumbricals are there? So the lumbricals are, what are the functions of the lumbrical muscles? So lumbricals causes the flexion of the metacarpophalangeal joint and extensor of the interphalangeal joint. It's like this. And first two is your unipinnate, and it is on the lateral side or towards the thumb side. So it is getting attached, all of them are getting attached to the thumb side. So when we'll be holding the ultrasound probe, we'll be seeing the tendon, the flexor digitorum superficialis and flexor digitorum profundus tendon, round shaped tendon, and just by the lateral side of that, we'll be seeing that the worm-like, it's like black worm-like, the muscles of the lumbrical muscles. And the lumbrical muscles will be getting attached at the base of the proximal phalanx. So these are the lumbricals, and lumbricals are the more superficial muscles in the palm, and it is along with your most superficial tendons also, that is the flexor digitorum profundus and flexor digitorum superficialis. Now, if we are removing this layer of muscles, then we'll be having the interosseous muscles. And interosseous muscles are, let me remove the adductor muscles also. And here we are having few palmar interosseous and few dorsal interosseous. So first, let us talk with the palmar interosseous. Palmas interosseous. So palmas interosseous are 3 in number. How to remember why it is 3? 3 palmar interosseous and 4 your dorsal interosseous. Why to remember? How to remember? So here you see that the function, you have to remember the function of the palmar and the dorsal interossei. The palmar interossei are the adductor. It adducts. So where it will adduct? This is the middle finger. This is the middle finger. That means the third metacarpal bone. So these bones will be coming towards your middle finger. So now we already know that the first or thumb is having a very strong adductor muscles. It is having the two head, oblique head and the transverse head. So they don't need any additional adductor. But all other four, they need adductor. But middle one, it also don't need adductor because it is in the middle. So all other will be coming towards the middle finger. So it also don't need adductor. So that means out of 5, thumb don't need adductor, middle finger don't need adductors. So other 3 needs adductor. So that means we need 3 adductors, and these 3 are the 3 palmar interossei. So if it is adductor, it has to be on this side, towards the middle finger. So this first one, it is getting attached from this side. You should be calling it as the first one. This is the second one, and this is the third one. So first one, it is getting attached with the shaft of the second metacarpal bone and getting attached with the medial side of the proximal phalanx. The third one, where it will be getting attached, where it will be getting origin. Origin is again from the 4th. So third palmar interossei is getting originated from the 4th phalangeal bone, shaft of the the metacarpal bone, and shaft of the 4th metacarpal bone, and getting originated and getting inserted into the base of the 4th proximal phalangeal bone. Which side? It is on the lateral side because it has to come towards the 3rd, so it has to be on the lateral side. Same way, the 3rd palmar interossei is originated from the 5th metacarpal bone, shaft of the 5th metacarpal bone, and getting inserted on the lateral side of the proximal phalangeal bone at the base. So these are your 3 palmar interossei muscles. So just quickly again remember, why 3? Because first one don't need any adductor. Third, it don't need adductor because it's the center. So all other will be coming towards it. So first and third, they don't need. So which other needs? Second, 4th, and 5th. So the second, the muscle is your first, the palmar interossei. The second interossei will be on the 4th shaft of the metacarpal bone, and the 5th, the 3rd palmar interossei will be getting originated from the 5th metacarpal bone at its shaft and getting inserted in the base of the proximal phalanx. So this was your palmar interossei. Now come to the dorsal interossei. The dorsal interossei are, remember, dorsal interossei are abductor. So again, the first, they don't need an abductor because it has its own abductor pollicis brevis. The 5th, it also don't need any abductor because it also have the abductor digiti minimi. So both of them is very strong abductor of the 1st and the 5th. That means the middle 3, they need abductor. But again, the middle one, that means 3rd, they can be moved on the either side. That means it needs 2 abductors. So how then you have to remember how many? So the second, who needs an abductor, must have 1. The 4th, who needs an abductor, must have 1. So 2. And the middle one needs abductor, which will be acting on the either side. So it needs 2. So that means we need 4 dorsal interossei muscle. So now, how to remember where it will be getting attached? So the middle one on either side will be having 1 dorsal interossei muscle. So middle one, that means the 3rd metacarpal bone, have 2 the dorsal interossei muscles on the either side. And again, it is getting attached to the base of the proximal phalanx. Then either of that, then again, it will be having, so it will be 2nd and 3rd. And the first one will be getting attached at the after between the first and the second, and the SAPT, and getting attached at the second proximal phalanx. And in the same way, the fourth palmar interosseous will be getting attached there. So if you are holding the ultrasound probe here, so what we'll be finding? So we'll be getting the, if we are making the center of our probe over the middle phalanx, that means the third metacarpal bone. On either side, we'll be having the dorsal interosseous muscles, and then on this side we'll be having the palmar, and then on this side and this side we'll be having the dorsal the palmar interosseous muscles. So keeping that in mind, that we are having the palmar interosseous muscles and the dorsal interosseous muscles, and they'll be alternating. Except for that, around the middle finger on the either side, there will be dorsal and then alternating. After the dorsal, then palmar, then again dorsal. In that way, you have to remember. Okay, so up to this much. Okay, no, I have to talk about the few other things, particularly the pulleys, the connective tissues, and then some other, the palmar plates, and the dorsal tendons as well. So I forgot to mention that. So let me add these things. Let me remove the muscles first. Okay. So okay. So let me enlarge a little bit. So to hold our flexor tendons, because when you are making a fist, our tendons are not going, it is not coming out of the fingers. So because there are several pulleys are there. So there are few annular pulleys, A1, A2, A3, A4, A5. 5 annular pulleys are there. So how to remember? So these annular pulleys are, first annular pulleys is between the metacarpal bone and the first phalangeal bone. So this is your A1 pulley, first annular pulley. And then third annular pulley over the joint between the proximal and the middle phalanx. And then the fifth annular pulley. So how to remember? Odd ones. First, third, and fifth, they are over the joints. And the second and the fourth, they are over the SAPT of the phalanx, SAPT of the proximal phalanx or the middle phalanx. So these are the 5 annular pulleys. Out of these 5 annular pulleys, this is the A1 pulley, which is very important to us, because trigger finger is because of the thickening of this A1 pulley. So again, let me repeat, there are 5 annular pulleys we call A1, A2, A3, A4, and A5. The odd ones, that means A1, A3, and A5 are over the joints. So A1 pulley is the metacarpophalangeal joint. But again, one thing you have to remember, that this A1 pulley is partly over the joint and partly proximal to that. Not exactly over the joint, obviously, but it extends beyond, more proximally towards the SAPT of the metacarpal bone. But A3 and A5, sorry, they are exactly over the joint. And the A2 and the A4, the even one, they are over the SAPT of the proximal and the middle phalanx. And then we are having the cruciform pulleys. So cruciform pulleys, they are named as a 0, C0, C1, C2, and C3. So 4 cruciform pulleys. So they are crisscross, and they are basically holding these annular pulleys. So these are the different pulleys, the ventral pulleys, the annular pulleys and the cruciform pulleys, and they are holding our flexor tendons in place. And one very important pathology here is your trigger finger, that will be discussed in detail by Dr. Siris. Another important things to remember here is these structures. I'm enlarging it. So these are the palmar plates. So over this metacarpophalangeal and the palmar joints, so metacarpophalangeal joint, then the proximal and the distal, the interphalangeal joints, we are having some cartilaginous plate. This cartilaginous plate is bridging, on the either side, lateral, the medial side, and makes a groove, a fine groove through which the tendons basically glides, and it holds. And there is injuries of this palmar plate, particularly, the different types of injuries are there, the palmar injuries, where this palmar plate might be injured. Any of the palmar plate might be injured, but the most common palmar plate which is injured is your metacarpophalangeal joints, metacarpophalangeal palmar plates. So now this was about in the dorsal side. Okay, another thing I forgot to mention is the ulnar collateral ligament of the thumb. So ulnar collateral ligament of the thumb is here, which is on the ulnar side. So this was your radial side. This is the ulnar side. So here, between the proximal and the proximal phalanx and the first metacarpal bone, so there is a strong ligament which holds the thumb when we are flexing and we are gripping, and this ligament is known as the ulnar collateral ligament of the thumb. So the ulna is not here, so you should not be getting confused where from the ulna is coming, but basically it is on the ulnar side of the thumb. So that's why this is known as the ulnar collateral ligament, which is giving the support, gives the stability, particularly when you are gripping it or flexing the thumb, and it holds it, and it is between the first metacarpal bone with the proximal phalanx of the thumb. Coming to the dorsal side, so we are having the extensor tendons. The extensor tendons, again, it is getting stabilized there, and these are the extensor tendons. So this extensor tendon, again, like we are discussing, that the different annular and the cruciform pulleys was holding the flexor tendons. The same way, the extensor tendons are placed in position by the sagittal bands. So sagittal bands are what? These are the extension from the palmar plates, which comes on the either side, and it holds the extensor tendons in position, and it is not allowing it to slip. So it comes from here. So these are the sagittal bands on the either side. So it is not shown here nicely, but I'll be showing you on the ultrasound. It comes from the either side from the palmar plate, and it holds the extensor tendons. Either side it is holding, so it is not slipping on the either side. So this is about the muscles, tendons, ligaments. So if you are having any questions on the 3D anatomy, you can ask me. Otherwise, I'll go for the demonstration. Any questions?
What's the name of this application?
What's the name of?
This application, anatomy, 2D or 3D?
Okay, this is Elsevier 3D anatomy software. You can search it, Elsevier 3D anatomy software.
Okay, thank you.
If you wish me to repeat any of these structures, because we must be knowing the anatomy very nicely, then only you'll be able to learn this other things.
Sir, attachment of flexor and extensor tendon.
Huh?
Attachment of flexor and extensor tendons.
Okay, attachment, right. So the attachment I forgot to mention.
Yes.
So where it is getting attached, let me remove it, the connective tissues, so that you can understand. So what happens, the flexor here, there are two tendons, two flexor tendons, flexor digitorum superficialis and profundus. So what happens, you see, when it comes to the, the proximal phalanx, the superficial one, it splits and it goes on the either side of the flexor digitorum profundus. Goes either side, and then it's going below it. It goes below it. See, it goes below, and it gets attached to the base of the middle phalanx. And the flexor digitorum profundus, they extends up to the distal phalanx, and it gets attached to the base of the distal phalanx. We'll be tracing this up to the distal phalanx. So this about the flexor. And for the extensor, so here it is only one tendon, but again it gets splits. So there are two slits on the either side, and they will be going more distally to get attached to the base of the distal phalanx, and the middle part it will be getting attached at the base of the middle phalanx. Okay, is it okay?
Okay. Yes, sir. Thank you, sir.
কোনটার সাথে লাগানো আছে? আচ্ছা, ওটাকে ফ্রিজ করে রেখে দে, যদি কোনো সমস্যা হয়। এটাতে যদি কোনো স্ট্রাকচার ঠিক মতো দেখতে না পান, তখন ওটার ক্ল্যারিটি অনেক বেটার। Okay, so all of you can see my volunteer's hand. Okay, let me do one thing. Let me remove, sorry. Let me remove this. So I'll start with the thinner muscles. And if you can remember, what was the thinner muscles? Most superficial one was abductor pollicis brevis. So let me annotate. So this muscle was the abductor muscles. Superficial one, the most superficial one was abductor. And where from it is getting originated? It is originating from the scaphoid. So this was from the scaphoid, and where it is getting attached? On the lateral side of the base of the proximal phalanx. So my aspect marker is towards the lateral side. And what I am trying to search? I am trying to search this tubercle. So what was this tubercle? It is the scaphoid tubercle. And okay. So that was the proximal carpal tunnel. You can remember, this was the proximal carpal tunnel, and you all can remember the content of this proximal carpal tunnel. So this was the proximal carpal tunnel. So this was the scaphoid. So what I am doing here, I am putting the scaphoid bone tubercle, and I am rotating it. So my left hand side is still on the scaphoid, and now what I am getting is your trapezium and the base of the proximal phalanx. So if I am here, so what are the muscles we can see? So you can see this was your scaphoid. This was your trapezium. This was the base of the metacarpal bone, first metacarpal bone. So these muscles, the most superficial muscle was your getting attached here, was your what? Abductor pollicis brevis. After that, here is your the opponent's pollicis brevis. If I'm going little more medially, then only the second layer muscle is here, basically the flexor pollicis brevis, but the flexor will be coming little later when we'll be sliding the probe little more medially. Again. So this was your scaphoid. So the most superficial muscle that was coming and getting attached there was your the abductor. And after that, getting attached for the trapezium is your the opponents. And if I am sliding my probe more medially, and now the flexor is coming. So this was your flexor. And if I am coming sliding, so this is whole is your flexor pollicis brevis. And now this is your flexor pollicis longus. So in the middle of the flexor pollicis brevis, what you can see here is your flexor pollicis. So now it's fine. So what you can see here, this muscle not muscle, it's basically tendon here. So this is your flexor pollicis longus. And above that is your flexor pollicis brevis. This is also flexor pollicis brevis. So I was here. The flexor pollicis longus in the middle, and above and below was your the flexor. So this distal. Okay, let me hold like this. Okay, so holding means your proximal side is your. The left hand side is your proximal side, and the right hand side is your distal side. So now, where the flexor pollicis is getting attached, it is getting attached to the distal phalanx. So I am not going up to that. So I'm just from here. See what I'm doing. I'm rotating the probe. I'm rotating the probe towards where? I'm rotating the probe towards the. You see now the second phalanx, second metacarpal bone is coming. So and some muscle is appearing there, and this muscle is the oblique head of the. So again, let me come from here. This was the home page. This was the home page. The very bright white, the tendon of the flexor pollicis longus. From here, I'm keeping the proximal side, distal side fixed. And what I'm showing, look at my probe, proximal side. But this side I'm fixing, and I'm rotating the proximal side. And if I'm rotating the proximal side, so one muscle is appearing. And this is your. So this whole muscle is the horizontal. So here it will be the second and the third phalanx will be coming. So I'll be showing that is your oblique head of the adductor pollicis brevis. Adductor pollicis. So again, let me come from here. Okay. The problem is it cannot the right hand side. So again, this was the home page. With the home page, so when I'm trying to change it, so my screen is changed. Okay, so now here you can see the middle, above and below was flexor. So this was your flexor pollicis. Above that was abductor pollicis, and I'm just rotating the probe. When I'm rotating the probe, what I'm getting is your. This is your oblique head of the adductor pollicis. And then if I'm still rotating, the muscle heart will be coming. So now this is your transverse head of the adductor pollicis. So this is your this. So this muscle is your transverse head of the adductor pollicis. So adductor pollicis, as we mentioned, the adductor pollicis have the two bands. One is your oblique, another is your transverse. So when you are holding the probe like this, you can see the oblique head, and when you are rotating the probe like this, we'll be able to see the transverse head. So these are your thinner muscles, and then come to the hypothinner. So hypothinner, from where we should start? We should start from pisiform. So pisiform, you can palpate, or we can also go like this, the carpal tunnel. So you can see the Goyan's carpal tunnel. This is a part of the Goyan's tunnel. You can see the ulnar artery, ulnar nerve, and the flexor carpi ulnaris muscle, tendon, sorry. And I'm keeping that on the left hand side of my screen. So this bony tubercle is your pisiform, and I am rotating it. So the muscle what will be appearing will be your abductor digiti minimi. So this muscle is your abductor digiti minimi. Please. So this muscle is your abductor digiti minimi getting attached over the pisiform. This is the most superficial, and it is much broader than the other hypothinner muscles. Then what I do? Then, as I told you, other two muscles are deeper. One is your flexor digiti minimi, another was the opponent's digiti minimi. Opponent's digiti minimi is most and they deeper, and flexor digiti minimi is the in between. So where from they will be originating? They will be originating from the hook of the hamate. So when I was holding the probe like this, so I was getting the pisiform, and I do like that. So now what I do, I'll be coming little more distal, and then pisiform will be disappearing. So now pisiform has disappeared, and now below the ulnar artery, one bone will appear, and that is your hook of the hamate. You can see this is the bone. This is the bone. This is the bone. So hook of the hamate is normally seen as a very small, and below that hyperechoic area, and below that will be the acoustic shadow. So what I am doing here, I am fixing my probe here over the hook of the hamate, and now I am rotating it. You just keep the hook of the hamate is there. That hyperechoic, very small, tiny hyperechoic below the ulnar artery, and now I am rotating it. And now the muscle heart is appearing. Muscle heart is appearing from the hook of the hamate. Is here. The two muscles are appearing. So the two muscles are appearing. Is your flexor. This one is flexor, and this one is your opponents. So here we are having the three muscles, like the thumb side. We are also here having the three muscles. One is your abductor, most superficial. There is your flexor, abductor digiti minimi, flexor digiti minimi, then opponents digiti minimi. So now let me come to the lumbricals. Lumbricals, as I told, how to identify the lumbricals. So we have to first identify, and you have to put a lot of gel there. Otherwise, you will not be able to identify the lumbricals. So we'll be following the flexor, digitorum superficialis and profundus, and we'll be following that. We can follow this flexor, digitorum superficialis and profundus from the carpal tunnel. So this was the carpal tunnel. This is the proximal carpal tunnel. You can see the tendons, flexor, digitorum superficialis and profundus tendon. So This is your flexor pollicis longus on the left hand side, most left hand side. Rest all the tendons are flexor digitorum superficialis and profundus. So when I am just in between, these all tendons are together, except for this. This is also a content of the carpal tunnel. Last day I told you the flexor pollicis longus. Apart from that, all other 8 tendons, they are together. Some tendons are very nicely seen. So now the tendons are seen very nicely. So now they are all tacked at the carpal tunnel. Now when we are coming beyond that, you see some black things are appearing. Can you appreciate? Some black things are appearing here. Some black things are appearing. Now follow those things. I told you these are like worms. You see, some black things are appearing. Just lateral side of each of these tendons. These are lumbricals. These are lumbricals. Teach. Okay. So these are lumbricals. So this was the first lumbrical. This is the one tendon, another. So the first, second, third, and fourth is on this side. So these are the 4 lumbrical muscles. What is appearing there? And here, this was your middle phalanx. That means your third metacarpal bone. And what we told below will be what? This muscle was what? This muscle, these are the 2 layers. This is our transverse bands of the adductor pollicis. Okay. So now here, this was the middle. So the middle, what you have to remember? That middle on the either side, will be having the 2 dorsal interossei. After that, here it will be 1 palmar interossei. Here also will be palmar interossei. And this was your, if I'm coming to the other side, we'll be getting palmar dorsal in that way. So just follow these things. Again, let me clear the drawing. So all of you, I hope all of you have understood the, let me reduce the little bit of, then you'll be able to appreciate it better. Just give me time. Let me adjust the screen a little bit so that you can appreciate get the whole screen. And okay, I have reduced the screen size so that you can see all the things. So what I was showing you here, that besides this one was your first lumbrical, this is the second lumbrical, third lumbrical, fourth lumbrical. Earlier you was unable to see on this side. And this was the horizontal, the transverse band. And here we are having the interossei. As I told you, the third. So beside the third on the other side, you are having the dorsal, then your ventral, then your dorsal on this side. and this was your ventral, dorsal. This was your ventral, and this is your dorsal. So in that way, we have to remember the ventral and the dorsal interosseous. I am showing you these things again. So what I was doing, so I was starting from the carpal tunnel. So in the carpal tunnel, my aspect marker is towards the thumb side. So in the carpal tunnel, you can see here the scaphoid bone and the pisiform bone, and you can see all the things, ulnar artery is dancing nicely. So now I am going distally. So now the pisiform, now the hook of the hamate is just below the ulnar artery. I can press it against the ulnar artery, and I am going still beyond. So now when we are following these tendons, so now some black things are appearing. These black things are basically the lumbricals. So now the lumbricals is entered in between the tendons. And now when you can see this, we can see the lumbricals here, and we can see the interosseous muscles also. Please. Okay, so this was your, let me put the annotation on. So this was the middle phalanx, that means third metacarpal bone. And this muscle was the horizontal band, which is getting attached with the second and the third metacarpal bone. This was tendons, and this was your lumbricals. And this is on the either side of the third metacarpal bone is your dorsal. So if it is dorsal, this will be your palmar. This will be again palmar. This is your dorsal. This will be your palmar on this side. So total, the 7, another is here. That is your dorsal. So 3 palmar, as I told you, I explain you why there are 3 palmar and why there are 4 dorsal interosseous muscles. So palmar interosseous muscles are the adductors, and the dorsal is your abductors. So there are 4, and some needs, some don't needs. I explain this. So this is the interossei and the lumbricals. Let me clear the drawing. Okay. So now I'll be going to trace the individual tendons. So as I was telling you, if I am tracing the tendon 1, so I am tracing this tendon, you can see clearly there are flexor digitorum superficialis and profundus. The superficialis is above and below is the profundus. So now I am at the level of the metacarpal bone. Now I am going, so I am entering into the proximal phalanx. So when I am going into the proximal phalanx, the extensor now it will be getting splitted, and now it will be getting below the flexor digitorum and getting arrested. So again, so we are coming from here. You can see clearly the 2 tendons, and then the superficialis will be splitted. It will be going on the either side of the flexor digitorum profundus and going on the side and little below and getting attached. So here it is getting. Now let me trace the flexor digitorum, flexor pollicis longus. So flexor pollicis longus, let us trace from the carpal tunnel. So in the carpal tunnel, this was the carpal tunnel, and flexor digitorum is, if you are moving it, this is the flexor digitorum. So now I am following it. So this very bright white is a flexor digitorum. Now where it is? Now it is in between the two heads of the adductor pollicis. So now it is coming, I am in the level of the proximal phalanx. And now it is getting attached at the base of the distal phalanx. So now it is getting attached here at the base of the distal phalanx. So this was your flexor pollicis longus. Okay, so now let us come to the pulleys. A1 pulley is most important, but other pulleys as well. So my aspect marker is towards the proximal side. That means left hand side is the aspect marker. So now what bone we can see here on the left side, you can see the two bone. So please come. So what you can see here. So this was the head of the metacarpal bone. This was your proximal phalanx. So you can see clearly the two tendons, superficialis and the profundus. And here, this black area is the A1 pulley. So A1 pulley, what I was telling you, A1 pulley is over the joint. This is the joint line, but it extends little bit more proximally, proximal side. Other pulleys are exactly over the joint, but that is not true for the A1 pulley. And this is your palmar plate. This is a palmar plate. This is a fibrocartilaginous structure. It makes a groove through which the flexor digitorum profundus and the superficialis basically glides. So now, if I am following that distally, we'll be able to see the other pulleys as well. Again, let me put a lot of gel so that So I was here. Left hand side was the metacarpal bone. You can see the palmar plate very nicely. So I'm going distally. So you can remember A1. After that, A2 is at the middle of the proximal phalanx. Then you can see another palmar plate. So this is another palmar plate above which the extensor tendons lies. And just above that is your A3 pulley. So A2 pulley, it's at the middle of the very thin black line is in the above the tendon is in the middle of the skin. Let me bring in the middle of the skin. That is your A2 pulley. And after that, this black line over this joint line, I told you that it is exactly over the joint. A1 pulley is little bit more extends more proximally. So A3. Then over the middle one is coming the A4, the black line again in the middle. Then your A4, so A3, A4 here and A5. The total 5 pulleys. Again, the black line over the joint line is A4 pulleys. Cruciform pulleys is difficult to see, but you can see these pulleys again in the short axis. So I'm putting my probe. I'm putting my probe over the distal end of the metacarpal. So what we can see here is, so this was your metacarpal bone, distal end, and this was your flexor digitorum and the superficialis and the profundus, and these black lines is your A1 pulley. And if we are looking that this A1 pulley is starting in this cross section, it is better understood. So if I am starting over the joint line, exactly over the joint line, see how you see this was the bone. Now here I don't have the bone. So that means I'm exactly over the joint. So A1 pulley is basically starting from there, from the joint line, and you see the pulley is there. And if I'm going more proximally, the pulley is becoming prominent pulley is still seen. I'm going proximally, and now pulley is no longer seen. Now pulley is vanished. So pulley extends little bit towards the proximal side. It starts exactly over here, over the joint. Now I'm over exactly over the joint because I can't see any bone. It is in the joint. Pulley starts from here and proximal. Now the pulley is more prominent. If I'm going there, I can. So now when we do the fenestration, so normally we can inject on either way. So just in our center, we normally put 2 needles. So I can come like this here and I can inject here in this pulley in this way. Or normally we put a needle like this and then we make a long axis also. And in the long axis also, let me clear this drawing. Okay, so the pulley this was the pulley. This black line was the pulley. This was the pulley. So it starts from the joint and goes little bit of. This was the pulley. So what do? We bring the needle like here, and with the bevel part of the needle, we fenestrate it. We multiple puncture, and we inject there. Normally give steroid, but PRP can also be given. But if you are doing only PRP or steroid, and if you are doing it fenestration plus the other medicines, the results is much better. So this is one of the common pathology, trigger finger, and that is because of the thickened A1 pulley. So here it is a thin pulley, but if it is thickened, then this is known as the trigger finger. Palmar plate also, I have shown you. This is your palmar plate. This is your palmar plate. Palmar plate injury is also not uncommon. Now come to the, okay, one ligament also I forgot to show. That is your ulnar collateral ligament of the thumb. Okay, so this was the metacarpal bone. This was your phalangeal bone. So this ligament is your ulnar collateral ligament, which was, as I told you, which gives the stability of the thumb when we are gripping. So now let me go to the dorsal side. So dorsal side, the extensor tendons. So the extensor tendon, I'm just putting over extensor tendon is very thin. So my aspect marker is towards the left side. And let me reduce the depth so that we can see it much better. So these are the extensor tendons you can see there. These are the extensor tendons. And when we are going, let me put more J, because here there is no muscles, no fat. So difficult to be, only bone, so difficult to visualize. So this was the tendon, extensor digitorum tendon. So I am trying to show you the sagittal band. So sagittal band is basically holding the extensor tendon from either side. It is there over the joints. Okay. Now the sagittal band is seen very nicely. So this was the extensor tendon, And this is your sagittal bands. It like inverted V, it comes and holds, and it is not allowing it to slip and going away. So sagittal band injury is also a kind of injury what I can see there. Okay, series, am I missing anything else?
Missing the recesses, dorsal and palmar recesses.
Pardon?
Dorsal and palmar recess.
Dorsal and palmar?
Recess of the joint, sir. The radio lunate and
Okay, those was in the part of the wrist itself.
okay, sir. Then we have covered everything, sir.
Okay. I'm just sorry it. And anybody wish to see anything again? Please tell me. So normally these two are not focusing much because in the chronic pain, the not much things are there, but still it is, we need to know everything in detail to be a good pain physician. So here is, so I'm holding at the middle and I'm showing you. So the proximal left hand side is the proximal side. So what bone you can see here? So this is your proximal side. That means this is the radius. So then this is your proximal row, and this bone is at the middle. What is that bone? This is your lunate, and this is your capitate. So this is the proximal part. That means this is your radiocarpal joint, and this is your mid-carpal joint. Mid-carpal joint means in between the first row and the second row of the carpal bones. So this is your capitate, this is your lunate, this is your radius. So if you go for the injection also, you can, and if there is an effusion, you can see that which joint is involved. So these joint capsules will be elevated and you might be going. And here the ligaments are there. The dorsal radiolunate ligament is there, and the intrinsic ligament which is joining the capitate and the lunate, that is also there. Okay, so this is on the palmar side, the dorsal side. We can go see also in the dorsal side. So dorsal side, palmar side. Let me increase the depth a little bit. Okay, so my proximal side, my left hand side of the screen, that means so left hand side is your radius, and then what are the bones there? Is correct. Okay, so this side was radius, this was your lunate, and this ligament you can remember. So I told at the middle it is your short radiolunate ligament, and this bone is the capitate, and this ligament extends up to the capitate, and this ligament is your short radiolunate ligament. So I'm unfreezing. So this part of the joint is from the palmar side. This is your radiocarpal joint, and this is your mid-carpal joint. So now, if I was here, and I can see very nicely the short radiocarpal ligament, and if I'm holding the bone over the distal end over the lunate, short radiolunate ligament, you can see. And now if I'm tilting the proximal part of then you can see the long radiolunate ligament. This is the long radiolunate, the ligament which is joining you can see my probe position. This is your long radiolunate. Again, this is the joint. This is how you can see between the radius and the lunate. And if I am holding the probe here, so distal end is over the capitate now. And if I am holding the distal end of the probe over the capitate, and if I am moving here, So now the ligament, what is coming there is your radio and scaphoid bone will come. Scaphocapital, sorry, not lunatic. This is your radioscapocapital. And here is your, what I have already mentioned there during my earlier when I was talking about scapito, lunate, there is ulno capital, ulno lunate. This is ulna, this is ulno lunate, this is ulno lunate, this is ulno capital. Ulno capital little bit comes over the lunate also, and ulno tricapital. So these are the short intrinsic and extrinsic ligaments and the joint bases. Okay, so anyone wish to see anything? Nothing? Okay, one thing I forgot. On 31st, that is Thursday, I will be basically going to Malaysia. So it will be difficult to demonstrate on that day. So what I'll do on 31st class, that is a knee, I'll be taking that class on 30th of August. So 31st, there'll be no class. So 31st class will be taken on the 30th. So all of you, please remember it. So 30th, 31st, there will be no class. The knee class will be on the 30th. Okay, so thank you very much. And series, if you are ready, and if
Yes,
you
sir.
have any questions or if anybody wish to see anything, they can ask me on the next class as well. Next class will be on hip.
Sir, is the slide
Yes,
visible?
your slide is nicely visible.
Okay, sir. Good afternoon once again. I'll be taking the common hand pathology. Last time also we went through these slides, and I think it will be a good revision for all of us. So after a very nice demonstration of anatomy and a scanning picture, I'll be going through some of the common hand pathology. As sir has already mentioned, the hand pathologies are very much limited, but we have to know a few of them which are very much common.
No, but yeah, series, I did told that it is limited. It is limited means the chronic pain I told. There are lots of
Chronic pain.
injuries in the hand, lot of injuries on their hand, but
Yes, sir.
normally they are not dealt with the pain physicians. But as I told you, the chronic pain conditions, which is one of the trigger finger, but some other things are also there. So,
yes, sir.
normally pain physicians are dealing with only few of the hand pathologies, but otherwise I should not say that it is uncommon. In the injuries, there are a lot of injuries are possible, and most of them I have covered in the anatomy, but rare in the sense of the chronic pain.
In chronic pain, sorry, I'm again correcting it. So in chronic pain, we'll be seeing a few of the hand pathology, common hand pathology that I'll be dealing in these slides. Okay. So coming to chronic pain pathologies, there are few of the lists that I've shown in the picture that are mainly related to pulleys and sagittal band, as far as nicely demonstrated the pulleys and sagittal band, and some with palmar fascia, and another is collateral ligament, especially the ulnar collateral ligament that sir has already demonstrated. And few pain origin or the pain generators are secondary to rheumatoid arthritis or osteoarthritis, and sometimes ganglia and foreign bodies are very much common in the hand also, because we'll be using hand to doing most of the manual works. And in these conditions, foreign bodies gets entrapped in the palmar aspect of the hand. That can be origin of the pain as well. So starting with pulleys and sagittal band, this is the most common, one of the most common hand pathology that we'll be visiting to our pain clinic. So as we all know, pulleys and sagittal bands are basically, these are the fibrous extension which arises from the palmar or volar plate, and it basically stabilizes the tendon which it covers. So pulleys are pulleys are basically dealing with the palmar aspect of the hand, and sagittal band basically are located in the dorsal aspect of the hand. And pulley stabilizes the flexor tendon into the fingers, whereas the sagittal band stabilizes the extensor tendon of the hand. And coming to pulley are basically of two types, as we have already known. And, so it is, first one is the annular pulley, and another is cruciform pulley. So normally it is 5 in number from second to fifth finger, but in thumb there are only 2 pulley because middle phalanx is absent. Similarly, the cruciform pulleys are the crisscross band which connects 2 annular pulleys, and it is either 3 or 4 in number. In some books it says 3, and in some books it says 4 in number. And in thumb it is only 1 in number, and it is known as oblique pulley in the thumb. So as we are dealing with most of the pathologies of the pulley is usually associated with A1 pulley. A1 pulley is the length of A1 pulley is about 12 millimeter normally in adult index, middle and ring finger, and it is about 10 millimeter or 1 centimeter in the little finger. So this is the in the lower side, you can nicely see the pulley in the left hand side, and number is 5. And as already mentioned, the odd number pulley are located just over the joint. So in the metacarpophalangeal joint, A1 pulley is located. In the proximal interphalangeal joint, A3 pulley is located, and in the distal interphalangeal joint, A5 pulley is located. And over the shaft is the even number pulleys are located. So A2 pulley is located in the shaft of the proximal phalanx, and A4 pulley is located over the shaft of the middle phalanx. And as you if you can see nicely, between the A2 pulley and A3 pulley, you can see the crisscross band, which is a C1 pulley, a C1 cruciform pulley. And between A3 pulley and A4 pulley, you can see another crisscross band, that is cruciform, second cruciform pulley. And between A5 and A4 annular band, you can see A3 cruciform pulleys. And these pulleys, annular as well as cruciform pulleys, they stabilizes the flexor tendon over the finger, and it prevents the flexor tendon from bowing. And if you see the right side, lower side of the picture, you can see 2 pulleys. Here both A1 and A2 pulley are located over the joint because middle phalanx is absent, and oblique pulley here is also known as cruciform pulley. Trigger finger is one of the most common presentation in the pain clinic regarding the hand pathology, and it is said that the lifetime prevalence is about 2.6% in general population, but it is slightly more in case of diabetic. It is 10% in diabetic population. And these trigger finger occurs mainly in A1 pulley, and the main pathology is basically because of increase in friction or mismatch in size between the pulley and the tendon, causing irregular flexion and extension of the fingers in the palm, and mainly in the metacarpophalangeal joint. So patient commonly presents with, initially they might present with a vague sense of tightness or pain over the metacarpopharyngeal joint in the initial phase. But in later phase, patient can have a locking or catching of the affected fingers during the flexion. And when we do the physical examination, we can also appreciate the nodular thickening over the metacarpal head in the affected tendon. And as shown in the picture, in the upper and lower part of the slide, you can see the nodular enlargement of the flexor tendon and just proximal to the A1 pulley. Similarly, in the lower side also, you can see the nodular swelling of the flexor tendon because of the mismatch of size between the pulley and the tendon. Once the pulley slides into the pulley, it gets locked. So this is basically a trigger finger. So there is one grading of trigger finger, which is also known as Cunel scale. And here there are 4 grading of the trigger finger. The grade 0 means normal movement of the finger during flexion and extension. In grade 1 there is no locking of finger, but there is uneven movement of the finger while doing flexion and extension, but there is no locking of finger. In grade 2, there is a locking of finger once the finger is flexed, but it can be actively corrected by the patient himself. And in grade 3, there is locking of finger, which cannot be actively corrected, but patient has to correct the trigger finger passively by extending the affected finger. And in grade 4, there is fixed deformity of the finger, so it cannot be corrected either by actively or by passively. So, and these are the basically grading. It is of very less clinical significance, but still we have to know the grading of the trigger finger, as it is very much common in day-to-day clinical practice. So if you do the ultrasound picture as Sir has demonstrated very nicely, I'm showing you the long axis view and short axis view of the pulley. And we basically examine when the patient with elbow extended and supinated hand, and we use high frequency linear probe of frequency up to 16 or 20 hertz. We can also use hockey stick probe for this, but a linear probe with higher frequency is also better for this. And if you see the left side of the picture, this is the long axis view of the A1 pulley. And if you can see nicely here, the position of the probe is just over the head of the metacarpal and the base of the phalanx over the flexor tendon. And in long axis view, you can see the head of the metacarpal as well as and the base of the proximal phalanx, and in between this joint you can see the palmar plate, and just over the palmar plate you can see the fibrillar pattern of the flexor digitorum superficialis and profundus. And if you notice, just above the flexor digitorum superficialis, which is shown with the yellow arrow, you can see a faint anechoic ribbon-like structure. So this is the normal A1 pulley. And Sir has already explained, this pulley can be better appreciated in the short axis view, which is shown in the right side of the slide. Here the placement of probe is just over the head of the metacarpal, and you can see a cross-section view of the metacarpal head in the lowermost part. Just above the metacarpal head, you can see a cross-section view of flexor digitorum profundus and superficialis. And over the flexor digitorum superficialis, you can see a black ribbon-like marking, which is shown with the yellow asterisk sign. That is the A1 pulley in the short axis view. And this pulley extends in either side of the flexor digitorum tendon as a triangular anechoic like shadows. This is also a part of the A1 pulley, which basically arises from the palmar plate, and it arches over the flexor digitorum superficialis and profundus and stabilizes the this flexor tendon in the finger. So these are few of the normal and pathological slides of the trigger finger. In the left side upper slide part, you can see the X-ray, the plain X-ray of the hand, where the flexor tendon and the location of pulley is shown. And in the sonographic picture of that, in the cross-section view is also shown in the side, where you can see the metacarpal head, flexor digitorum tendon, both superficialis and profundus, as well as the ribbon-like arch over the flexor tendon arising from the palmar plate, which is also shown with the white arrow marking. So this is the A1 pulley. So in the lower side of the same slide, you can see a thickening thickening and increase in hypoechogenicity of the tendon, as shown with the two white arrows. You can appreciate that the thin anechoic line is thickened and more hypoechoic. So this is the pathological part, which is also seen in the patient with trigger finger. So if you see in the right side of the slide also, here also you can nicely appreciate the increase in thickness of the A1 pulley of the thumb. and increase in hypoechogenicity as well. So if you see nicely in the left hand side, this is the A1 pulley of the finger, second to fifth finger, and the shape of the A1 pulley is parabolic in nature, inverted parabolic in nature. But in the thumb, it is circular in nature because it has to incorporate only one flexor tendon. But in finger, as it has to arch over the two tendons, it is parabolic, inverted parabolic in shape. So, the minimally invasive percutaneous injection we commonly do for patient with trigger finger, and we inject steroid triamcinolone and methylprednisolone about 10 to 15 milligram along with 0.5 ml of lignocaine. And this injection can be done both in long axis view as well as in short axis view. I have shown you the picture of injection, the site of injection in short axis view. Here you can see the diagrammatic view of the finger and the placement of the probe, as well as the direction of the needle, which is indicated by the red dotted line. And in the ultrasound picture also, you can nicely see the A1 pulley over the flexor digitorum tendon, and as well as its extension either side of the flexor tendon. So normally injection can be done above and below as well as inside the pulley. In this slide, I have shown you the needle trajectory as well as the placement of needle, which is shown in the white color, this dot over the inside the A1 pulley. So in case of trigger finger, we can inject on either side of the radial or ulnar side of the A1 pulley, and about 0.5 to 1 ml of local along with the steroid is injected in the short axis or long axis view. So another common problem associated with pulley that we commonly encounter in pain clinic is pathology known as rock climber's finger. Here, basically, there is a anatomical problem in the pulley. So basically, sometimes these pulley, not only A1, but other pulley A2, A3 pulleys, as well as cruciform pulleys can be ruptured due to repeated microtrauma or even during acute trauma, which we commonly see in rock climbers. And these pathology involves the middle finger and ring finger, and it usually occurs when the fingers is forcefully extended against the resistance. And as you can see in the picture in the left side, in the diagrammatic view, there is a rupture of A2 pulley, as incomplete partial rupture of A2 pulley, complete rupture of A3 pulley, as well as rupture of the cruciform pulleys in between A2 and A3 pulley. So once the pulley is ruptured, when the finger is forcefully extended, there can be this flexor tendon which used to be held near the bone by the pulleys will be lost, and there will be bowstringing of the flexor tendon as shown in the picture. And just below the diagrammatic picture, you can see the short axis view of the flexor tendon as well as phalanx. And if you see very nicely, the space between the flexor tendon, which is shown with the white arrow marking, and the hyperechoic phalanx, that is bone, there is a increase in space between the flexor tendon and the bone. So this means the pulley which used to bind the flexor tendon near to the bone is ruptured, and there is a black anechoic the structure between the flexor tendon and the bone. So that indicates there is a effusion, mainly the blood in between the flexor tendon and the bone. So that basically denotes that there is the rupture in the pulley in the site where we are examining. So if you see the right side of the slide also, I have included both the long axis and short axis view of the ruptured pulley. I think because this is the proximal phalanx, so it is the A2 pulley, rupture of A2 pulley. So you can also appreciate the distance between the flexor tendon and the hyperechoic bone. In between these two, there is a black anechoic or hypoechoic structure. So basically, this indicates that the pulley that used to stabilize the flexor tendon is ruptured, and this part is occupied with the bloody effusion or fluid in between the tendon and the bone. Similarly, if you see the short axis view also, here also the tendon, flexor digitorum tendon is not in close proximity with the proximal phalanx. There is a space in between the flexor tendon and the proximal phalanx. So this means there's a accumulation of the blood in between the flexor tendon and bone because of rupture of pulley. So this is commonly seen in the rock climbers involving middle and ring finger. So there is another common pathology which I'll be coming in later slide also. I'm just posting this picture because it is related to pulley. In pulley also there can be a ganglia arising from the pulley. So you can here clearly see a well-defined cystic-like anechoic cyst-like mass over the pulley. Here you can see if you see from the lower part of the picture, there is a bone, hyperechoic bone. Just above the hyperechoic bone, you can see flexor digitorum tendon and pulley. And above the pulley, you can see the well-defined anechoic cystic mass, which is basically a ganglia which is arising from the pulley. So another common problem in the hand is associated with the rupture of the sagittal band, and as sir has already explained, these sagittal band are also the fibrous extension which arises from the palmar plate, and instead of stabilizing the flexor tendon, these sagittal bands are located in the dorsal aspect of the hand, which stabilizes the extensor tendon. And you can see the head of the hyperechoic bone, that is metacarpal head. Just over the metacarpal head, you can see the extensor tendon. And on either side of the extensor tendon, which is shown with the white arrow, are the sagittal band, which arises from the palmar plate, and it arches over the extensor tendon and it stabilizes the extensor tendon. So sometimes there can be a rupture of sagittal band, which is very much common in boxers due to the repeated microtrauma. So in these conditions, the extensor tendon can be dislocated, and normally the direction of dislocation is contralateral to the band which is torn. So if you see in this slide, I have included, this is the dynamic scanning of the sagittal band. So the picture A is basically when the fingers is extended, and when the fingers are extended, you can see the extensor tendon lying over the metacarpal head, and you can see the sagittal band on either side. But if you see nicely, the right side of sagittal band, the echogenicity has increased. But in the left side of sagittal band, it is normal ribbon-like structure is there. But if we flex the finger, then you can see now the extensor tendon is no more over the metacarpal head. It has dislocated to the left side of the metacarpal head. And this basically says that the sagittal band, which was holding the extensor tendon over the metacarpal head, is torn, and the extensor tendon is now dislocated to the side of the metacarpal head. And this dislocation occurs. So if the tendon is in the left side of the metacarpal head, that means the right side of the sagittal band is ruptured. Similarly, in picture C also, you can see the metacarpal, above the metacarpal head, there is no extensor tendon. This extensor tendon has been dislocated to the left side of the metacarpal head. That means right-sided sagittal band is ruptured, and this usually it is seen when the in the dynamic movement of the hand finger, when the finger is flexed and extended. So another common problem that we encounter in hand is problems related with palmar fascia. So the palmar fascia are basically, these are the direct continuation of flexor retinaculum and palmaris longus tendon. And these palmar fascia covers the flexor tendon and other neurovascular structure, as well as the lumbricoids and the intraosseous muscle in the palmar aspect of the hand. And this palmar fascia consists of longitudinal superficial fibers and deep transverse fiber. And these palmar fascia extend more distally, forming 4 bands, and these bands are attached to the base of the proximal phalanx. And from this palmar fascia, about 9 vertical septas arise, and these vertical septas helps to connect the palmar fascia to the deeper structure, mainly the carpal bone and the metacarpal bones. And there are normally 9 vertical septa, 2 marginal septa on either side, and in between these 2 marginal septas, various 7 or 8 various intermediate septa also arises, which helps to connect the palmar fascia to the deeper structure. So one of the most common problem associated with this palmar fascia is Dupuytren's disease or contracture. And as you can see in the picture, in the Dupuytren's disease, there is a nodular thickening and variable degree of retraction of the palmar fascia. When this happens, patient usually presents with painless nodule over the palmar aspect of the hand, and contracture as well as limited mobility of the fingers that are affected. And normally this Dupuytren's disease or contracture is seen in elderly patient above age of 50, and it is more common in male. The ratio is about 7.6:1, and this Dupuytren's contracture has a very strong genetical predisposition, and it is transmitted as autosomal dominant trait, and it is very much common in manual workers also. So as shown in the picture, you can see various few nodules arising over the palmar fascia and contracture of the little finger and ring finger. So this condition is known as Dupuytren's disease or contracture. And if you see the ultrasound, if you do the ultrasound of the hand, you can see hypoechoic nodule between the flexor tendon and subcutaneous tissue. And if you see nicely here, you can, in the upper part of the slide, the cross section as well as long axis view is shown. In the cross-section view, in the left side, you can see the hypoechoic nodule between the flexor digitorum superficialis and subcutaneous tissue. So these are the Dupuytren's nodules. Okay, so also it is like in the you saw the increase in echogenicity of the pulley here, not in the thumb, not in the finger, but over the palm. You can see the hypoechoic nodule over the flexor tendon. So this is basically a Dupuytren's nodules. And if you see nicely, you can see the nodular extension of the Dupuytren's nodule over the in the deeper structure, extending up to the bone of the carpal bone, and impingement of the flexor tendons in the lower part of the slide. In the lower part of slide, in both of the picture, you can see nodule which is impinging the flexor digitorum superficialis and profundus, and the nodule is extending deeper to the hand, small bones of the hand. So this is a typical ultrasound picture of the Dupuytren's disease. So another common pain pathologies are associated with collateral ligaments, so ulnar collateral ligament of the hand, and we are more concerned with the problems associated with the ulnar collateral ligament of the thumb, because as thumb, basically the 50% of the hand function of the hand is associated with the thumb, which helps in gripping or grasping or pinching. So when the ulnar collateral ligament of the thumb is in if there is any pathology, then these function will be lost. Okay, so as we all know, the metacarpophalangeal joint and interphalangeal joint are basically, these are the condyloid joint, and the integrity of this joint is maintained with the radial and ulnar collateral ligament, as you can see in the picture. In the metacarpophalangeal joint as well as in proximal interphalangeal joint of the thumb, there is a ligament in the radial side as well as in the ulnar side. So the ligament which is in the radial side is known as the radial collateral ligament, but the ligament which reinforces the joint located in the ulnar side of the joint is known as the ulnar collateral ligament. And most of the pathology of ulnar collateral ligament is associated with the thumb. Okay, and normally the length of this ulnar collateral ligament is about 12 to 14 millimeter in length, and it is about 4 to 8 millimeter thickness. And it basically originates the ulnar collateral ligament of metacarpophalangeal joint originates from the dorsal aspect of the first metacarpal head, and it passes over to the palmar aspect, and it is inserted in the tubercle of the proximal phalanx. So most common pathologies associated with this can be associated with acute trauma, for example, skier's thumb, or it can be chronic microtrauma of this ulnar collateral ligament known as gamekeeper's thumb. And in skier's thumb, there is basically acute traumatic radial hyperabduction of the thumb, causing either sprain or partial tear or complete tear of the ulnar collateral ligament. In this picture, you can see a complete tear of ulnar collateral ligament when the thumb is acutely hyperabducted, and the integrity of this the metacarpophalangeal joint is lost. Okay, so this is skier's thumb. And in gamekeeper's thumb, basically gamekeeper's thumb is a chronic condition. When there is chronic microtrauma of this ulnar collateral ligament, the ligament can be lax and non-functional. Basically, there is no sprain or tear, but the ligament becomes too lax and non-functional, so that the normal activity of hand like grasping, pinching will be very much difficult. Okay, sometimes if in case of skier's thumb, the rupture of the ligament can be associated with avulsion fracture, as shown in the picture. You can see the ulnar collateral ligament is ruptured, and you can see a part of bone which is pulled away with this ligament. So that is skier's thumb with avulsion fracture of the phalanx. So in this picture, in the left side, you can see in the upper part of the left side picture, you can see this is the ultrasound picture of the ulnar collateral ligament of the thumb. If you see very nicely, this is the metacarpal head and the proximal phalanx. And this metacarpal head and proximal phalanx is connected with the hypoechoic arch. So this arch over the metacarpal head and proximal phalanx is the ulnar collateral ligament. And as you can appreciate, that the thickness of this hypoechoic the hypoechoic ligament has increased. And if you see very nicely, at the site of attachment of this ulnar collateral ligament, there is the hypoechogenicity has increased, or it can also be said that it is anechoic. So this basically shows it is shown with the white arrow. So there is a partial tear in the attachment of ulnar collateral ligament. So this is also one of the ultrasound picture of skier's thumb. And in the lower part of the ultrasound picture, you can see two retracted stump of ulnar collateral ligament on either side of the joint. So just over the metacarpal head also you can see the retracted ulnar collateral ligament, and over the proximal phalanx also you can see another retracted ulnar collateral ligament, and in between these two retracted portion you can see anechoic structure. So this basically denotes there is a complete rupture of the ulnar collateral ligament, and both are the example of the skier's thumb. So if there is a partial tear, we can go for PRP injection, but if it's complete tear like this, we have to refer the patient for the surgical correction of the ligament. So another common problem that is associated with the hand is rheumatoid arthritis. As we all know, rheumatoid arthritis is very much common, and it usually affects 0.5 to 1% of world population. It is a chronic systemic disease which usually involves the synovial membrane, and it is common in female. The causes of the rheumatoid arthritis is basically multifactorial, still unknown, and it is an autoimmune disease. And at the level of hand, basically wrist, metacarpal joint, and proximal interphalangeal joint are most commonly involved in rheumatoid arthritis, and it can affect joint, bone, tendon, subcutaneous tissue, as well as in the skin. So common features of rheumatoid arthritis in the joint will be, there can be joint effusion, there can be evidence of synovitis or hyperemia, or there can be evidence of joint space narrowing. And in case of bone, we can appreciate osteopenia or periarticular osteoporosis, subchondral bone cyst, or most commonly we'll see the erosion over the articular surface with the ultrasound. And in tendon, we commonly see tenosynovitis, enthesis, or there can also be full thickness tear or partial thickness tear in case of rheumatoid arthritis. And it usually involves flexor carpi ulnaris, flexor carpi radialis, as well as extensor carpi ulnaris and extensor carpi radialis. So this is the ultrasound picture of patient with rheumatoid arthritis. In the left side of the picture, you can appreciate tenosynovitis. You can see the anechoic or hypoechoic black color fluid surrounding the extensor tendon, as well as you can also appreciate, this is the picture of distal radioulnar joint. You can see the just over the 1 minute, my battery is running down. Okay, so just over, just distal to the ulna, you can see black effusion, which is marked with asterisk. So this is the effusion which we can see in those patients with rheumatoid arthritis. And if you see the right side of the picture, you can see in picture A, you can see tenosynovitis of extensor carpi ulnaris over surrounding a black anechoic fluid surrounding the extensor carpi ulnaris. In the picture B, you can see features of synovitis. And if you turn on the color Doppler, you can also see hypervascularization on the color Doppler as shown in this slide. So you can see over around the surrounding the extensor carpi ulnaris, there is a feature of synovitis, as well as if you turn on the color Doppler, you can see the lightening of the color Doppler, which shows there is a hypervascularization at that site. And if you see very nicely, you can see in the picture C as well as in the picture D, you can see a part of ulna, and you can see there is an erosion in the part of ulna. This is also a typical feature which is seen in the patient with rheumatoid arthritis. So there can be erosion of bone, can also be nicely visualized by the ultrasound in case of rheumatoid arthritis. So this is another ultrasound picture of same patient with rheumatoid arthritis. This is the dorsal palmar recess, as you can see in the radiocarpal joint. In the radiocarpal joint, you can see in the picture, left side of the picture, you can see features of effusion as well as features of synovitis between the scaphoid bone and the radius bone. There is a anechoic shadow extending from the radioscaphoid joint, and this is basically effusion associated with the synovitis in case of patient with rheumatoid arthritis. And if you turn on the color Doppler, we can see lightening of the synovitis, or you can see hypervascularization in the color Doppler. And and in the right side of the screen, if you see the picture, this is the cross-section view of the dorsal dorsal compartment of the hand. I believe it is a third or fourth extensor compartment, and you can see there is a fluid in the extensor compartment. That means there is the features of tenosynovitis. And if you see very nicely, normally fourth extensor compartment has 5 tendons, but here you can see only 3 tendons. That means because this is a case of chronic rheumatoid arthritis where there is a rupture of tendons, extensor tendon in the 4th extensor compartment, and along with the rupture of tendon, there is a effusion in the 4th extensor compartment. This is also typical feature of the ultrasound picture of patient with rheumatoid arthritis. Now coming to another common pain generators, that is osteoarthritis of the hand. So osteoarthritis of the hand is also very much common in pain clinic. So major site of osteoarthritis in hand is first carpo-metacarpal joint as well as distal interphalangeal joint. So in rheumatoid arthritis, proximal interphalangeal joints are more involved, but in case of osteoarthritis, most commonly distal interphalangeal joints are most commonly involved. And normally we see in the radiological picture, we can see narrowing of the joint space, cartilage lesion can be seen. Some subchondral bone sclerosis can be visualized. Osteoitis can be visualized. And in ultrasound, we can also see synovial hypertrophy, like we saw in rheumatoid arthritis, as well as joint effusion. So in the picture, you can see the X-ray, plain X-ray of the hand, as well as ultrasound picture of the proximal distal interphalangeal joint. If you see very nicely in the X-ray picture, you can, and if you pay close attention to the distal interphalangeal joint, you can see evidence of narrowing of the joint space, cartilage lesion, subchondral bone cyst formation, as well as subluxation of the middle finger as well as the ring finger. So this is a case of chronic osteoarthritis of the hand. And if you see the ultrasound picture, you can see this is the ultrasound picture of the distal interphalangeal joint. You can see erosion of the distal phalanx as well as proximal phalanx. You can also appreciate the synovial hypertrophy. So this is a typical feature of the ultrasound picture of the patient with osteoarthritis, where bone erosion as well as synovitis can be seen. And as the first carpometacarpal joint is most commonly affected in case of osteoarthritis joint, many patients come in pain clinic with pain in this first carpometacarpal joint. And this is the diagrammatic picture where you can see osteoarthritic first carpometacarpal joint in the left side. And in the same patient, this is the sonographic picture of the carpometacarpal joint. You can see in the upper part of the picture, you can see the placement of the slide to view the carpometacarpal joint. If you place the probe in long axis to the first metacarpal, and if you slide it towards the wrist, you can appreciate the metacarpal base of the metacarpal with trapezium, and you can see the first carpometacarpal joint. And if there is any erosion or any osteoarthritic feature in this, we can inject in this joint space with steroid. Nowadays we commonly use PRP as well. And in the lower part of the picture, you can see the placement of the probe as well as the direction of needle. Here we usually inject in the out of plane. Out of plane injection is done. As if you try to go in plane, then visualization of the needle and going inside the joint can be a bit difficult. So you can see in the ultrasound picture as shown with the red dotted line and white arrowhead, you can see a white dot, that is the needle placement area for injection in the carpometacarpal joint in case of osteoarthritis. Either steroid or PRP is injected. So another common problem that is commonly associated in pain clinic is ganglia. We all know many patients come with swelling in the hand will come in the pain clinic, and these are basically ganglia are most common swelling in the hand and wrist. So these ganglia are basically a space occupying lesion which is most frequently encountered in hand and wrist. They are also more common in females, and normally peak age of incidence is between the second to fourth decade of life. And basically these ganglia consist of gelatinous material which is covered inside the fibrous capsule, and this fibrous capsule can arise either from articular capsule, or it can arise from synovial sheet, or even with villi, as I have demonstrated in the previous slide, or it can come from the retinaculum also. And these ganglia are usually not painful, but if it's located inside the carpal tunnel, or if it's located inside the Guyon's canal, it can cause pain due to the pressure effect. So these ganglia presents as a firm, small to moderate size swelling which is poorly compressible, and in ultrasound it appears as a well-defined anechoic cyst-like mass which basically resists the compression. If you try to compress this cystic mass with the probe, then these are less compressible. And in this slide, you can I have included various position of the ganglia in the hand. So in the left-sided upper picture, you can see the well-defined and echoic cyst-like mass, which is arising from the radiocarpal joint. And you can see the hyperechoic bone are basically the radius and the carpal. And just over the hyperechoic bone, you can see oval shaped anechoic mass so this is the ganglia over the wrist joint, over the radiocarpal joint. And below this, you can see the ganglia arising from the pulley, as already demonstrated in previous slide. You can see the proximal phalanx, hyperechoic proximal phalanx. Just over the proximal phalanx, you can appreciate nice flexor digitorum and profundus tendon. And over the tendon, you can see a well-defined anechoic cystic mass. So this is the ganglia over the pulley. And if you see the right side of the upper part, you can see ganglia, which is arising from the retinaculum of the first dorsal compartment. And if you see the ultrasound picture, this is the cross-section view in the upper right side. You can see the yellow marking, the measurement, that is the measurement of the ganglia, which is arising from the retinaculum of the first dorsal compartment. And you can see the abductor pollicis as well as extensor pollicis in the first compartment. And in the lower part of the right side of slide, you can see the ganglia inside the carpal tunnel. So this ganglia is likely to produce pain, and this can mimic the carpal tunnel syndrome because of the pressure to the median nerve. In the left side of the ganglia, you can see median nerve, and on the right side of the median nerve, you can see an anechoic cystic mass in the carpal tunnel over the lunate bone, which is compressing the median nerve, and this can be one of the cause for carpal tunnel syndrome. And another common pathologies that we encounter in the hand are foreign bodies, as we do most of the work with the hand. So these foreign body, mainly glass, metal, and wooden splinter, can frequently find their way into the palmar soft tissue of the hand during our work or play. So this is very much common, such as glass as a foreign body, or metal or a wood can find its way into the palmar aspect of the hand and can cause pain. And if you see the ultrasound picture, all of the foreign body will be hyperechoic, but there are certain things that in the ultrasound picture by which we can differentiate whether it's a glass or metal or wood. So normally glass is hyperechoic, and it also basically presents with posterior reverberation artifact like metal. So there will be a reverberation artifact beyond the glass, which I'll be showing in the picture. And in case of metal, this metal will be much more highly hyperechoic than glass as well as wood. And there can be either acoustic shadow, acoustic shadow with the metal, or there can be reverberation artifact in the ultrasound. And in case of wood, the wood or thorn or any other particulate the wooden particulates will also appear as a hyperechoic object, but there will not be any reverberation artifact, or there will not be any acoustic shadow artifact in ultrasound. So this is the picture of the various foreign body in the hand. In the left side of the slide, you can see white hyperechoic structure, which is shown with the arrow. And beyond the white hyperechoic shadow, you can see the reverberation artifact. So this is the glass fragment in the hand. And you can also see the reverberation artifact beyond this white color artifact. So this is typically the ultrasound picture of the glass as a foreign body. And if you see the right side of the slide, you can see the X-ray picture as well as ultrasound picture of the foreign body. In the X-ray picture, you can see a highly hyperechoic structure just at the head of the near the head of the second metacarpal bone. So this is the metal foreign body in the hand, and if you do the ultrasound, you can see the highly hyperechoic artifact, as well as the posterior the reverberation artifact, which is by the metal. So this is the typical picture of the ultrasound picture of the metal as foreign body in the hand. And if you turn on the color Doppler, you can also appreciate the hypervascularization, as if there is any foreign body, there will be a granuloma formation around the foreign body. There will be increase in blood vessel formulation. And this is the typical presentation of the metal foreign body. Its artifact, reverberation artifact beyond this metal, and surrounded by the granular structure and hypervascularity of the granular structure. Okay, so, and this is another ultrasound picture of the foreign body, and as you can see, there is a white hyperechoic structure which is also shown with two arrowhead. And as you can notice here, there is no reverberation artifact, or there is no posterior acoustic shadow beyond this hyperechoic object. So this is, but this is typically done, we find it in wooden splinter or thorn as a foreign body in the hand. So, and there is also the anechoic or hypoechoic structure surrounding this hyperechoic object, that is basically a granulation tissue forming around the wood as a foreign body. So these are the basically common pathologies that we encounter in the hand. Of course, there are other pathologies which are associated with the rupture of tendon and rupture of tear in the lumbricoids, as well as in the other muscle of the hand, but they are very much less common. So these slides that I have included are the common pain generators in the hand, causing chronic pain and visit of patient in the pain clinic. Thank you very much. Hello.
Thank you, very serious. It was a very nice presentation. And
so I've included only the common pathology, sir,
yes,
not
yes.
any
There are a lot
muscular
of things, as I told. It was a very nice presentation.
Thank you, sir.
So participants can go again through the recorded videos again and again. As we told earlier, it will be available for till 31st of October. Next class, as I already mentioned, next class will be there on the Thursday, but 30th, 31st, there will be no class, and we'll be taking class on 30th instead, Wednesday, same time at 6.
Wednesday.
Okay, so thank you very much.
Any
Good night,
question?
and see the recorded videos.
Thank you. Okay, thank you, sir. Good night, sir.
Good night.